Yes, we are online. I think Professor Panasvardas will also join us in a minute or so. So it's my great pleasure and the pleasure of the organizers of this meeting, Sofia Mafrogeni and all the other people in the backstage, that we can start now with this session about interventional cardiac MRI. And I would like to introduce first the first speaker, Jérôme Garot, which is a well-known expert in this field. He also participates in the in a big study that we in Lausanne also participate for. Sorry, I forgot my name. My name is Jürg Schwitter. I'm head of the cardiovascular MRI section in the University Hospital in Lausanne. And so I want to introduce Professor Jérôme Garot. He is from the Jacques Cartier Hospital in Paris, doing a lot of interventional MRI procedures there. And he will show us his experience in this field, in particular with a difficult case with atrial flutter ablation. Jérôme, please give
Thank you.
Talk. Thank you.
Thank you, Jörg. I hope you can hear me fine. Thank you for the invitation. It's really an honor and a pleasure to be with you today and participate to this very nice event. If one wants to do ICMR Flutter ablation, you need to have a deep transformation of your CMR lab. In the control room, besides the scanner and the computer and screens and so on, you have to have a electrophysiology recorder and stimulator system with all the computers and display, an RF generator and generator command, and an irrigation pump with an irrigation line all the way through the ablation catheters. In the MR suite, you need to have an EP recorder and stimulator workstation that is connected to two RF catheter, ablation catheter and diagnostic catheter. You have to have this irrigation line through waveguides from the control room to the ablation catheter, and you have, of course, the display, the screens for the EP physicians in the MR room. For the catheters, you need steerable catheters, that's Vision MR catheters from the Imricor medical systems. You can see the catheter here. They are designed with a fiber optical temperature sensors at the tip of the catheter here in gold, and two solenoid tracking coils here in green. These are receiver coils, and they are mandatory for active catheter tracking. The catheters are connected to an EP workstation, as I showed before, and to the RF generator. For the patient case, it's a 60-year-old male who presented with a typical counterclockwise isthmus-dependent atrial flutter, and he signed consent for his participation in the visible AFL study. You can see the EKG here with the typical isthmus-dependent flutter. For the procedure itself, the patient is prepped on a dockable CMR table just outside of the CMR suite. Midazolam is injected intravenously at the time of venous puncture, and the venous puncture is made outside of the MR suite under echo guidance. Then two 9F introducers are placed in the femoral vein. Something important is that you have to acquire a baseline echo navigator, a 3D whole heart balanced SSFP sequence for the acquisition of full anatomy of the heart and the surrounding structures. We work on a Magnetum Sola 1.5 Tesla system. Then these images are transferred into a navigation system that is in the control room that is called North Star, and it allows for a segmentation of the heart and the creation of a 3D shell. That's the 3D shell you can see here on the right side of the screen. This shell will serve as a roadmap for ICMR and active catheter tracking. It can be displayed alone as a 3D shell or in combination with the MR, the native real-time MR images that you see here on the same image. For the navigation and the MR images, these are interactive real-time SSFP images, and you see that in-plane resolution is 2 by 2 millimeter, and it allows 6 frames per second. As I told you, the receiver coils here at the tip of the catheter, you can nicely see the receiver coils here on this image. And there is one diagnostic catheter that you can place here in the coronary sinus. Typically, we save 2 types of orientation of locations, the LAO here on the isthmus and the coronary sinus, and the RAO here, when you can nicely depict the inferior vena cava, right atrium, right ventricle, and PA. So the diagnostic catheter is positioned here in the coronary CS, and then the ablation catheter can be navigated in the right atrium for the ablation itself. That's the design in room where you have the 2 EPs. You need to have headsets for the noise, obviously, and you have 2 screens. On the left side, you can see the 3D shell and the interactive MR images, the real-time images, and on the right side, the intracardiac electrophysiology recordings. One of the beauty of MR is that you can nicely see the anatomy, of course, and it's important when you look at the cavo-tricuspid isthmus here, because it may have some particularities and complex anatomy, such as a eustachian ridge here that you can see here between the inferior vena cava and the isthmus itself. That's the eustachian ridge. But you can also measure the length of the isthmus up to the tricuspid valve, the thickness of the isthmus, the angle of the isthmus and the vena cava. And also sometimes we can see pouches in the isthmus. And it's very important to know the anatomic shape of the isthmus before you want to plan the targeted line you want to make for the ablation. Here, based on the anatomy, we knew that there was a ridge here, and from the anatomy, we selected to do a medial line from the tricuspid to the ridge here, a medial line that's in between the lateral wall of the right atrium and the interatrial septum. That's the navigation itself in the 3D shell. So you can see the tip of the ablation catheter here, and the other catheter is in the coronary sinus, the diagnostic catheter. But the ablation catheter, you can see the tip of the catheter, and you can see the shots, the RF shots that have been made between the tricuspid valve and the ridge here. It's important to know that it's a point-by-point ablation technique. You cannot do like in the EP lab, you cannot put your catheter here at the tricuspid valve and then drag a single line back to the vena cava. It's a point-by-point technique with each power delivered is around 50 watts during 1 minute. So it's a little bit longer and a little bit less convenient than in the cath lab for that reason. At the tip of the catheter, you can monitor the temperature and the impedance, which is something important. And usually between 15 to 20 shots are required to get the bidirectional block. Here, in this case, we started the ablation point from the tricuspid valve back to the inferior vena cava. But we failed to restore a sinus rhythm after 17 shots, which is a little bit unusual. So the physicians, the EPs, had to use the maximal torque of the catheter, as shown here, and go make a single point here, just behind the ridge, and then the sinus rhythm was restored after 1 shot. So we can check the bidirectional conduction block across the CTI. It's done like in the EP lab by differential pacing from two sides lateral to the CTI line, and by measuring the time delay between the pacing signal of the diagnostic catheter that's placed in the CS and local activation times. One of the other option, and I think it's very interesting and very important for this technique, is that you can make some images and visualize the ablation damage that you just made, the ablation lesion. You can do this with different sequences, of course, like T2-based sequences to see the edema, but you can use mapping, parametric mapping, dynamic perfusion, where you see perfusion defects, late GAD, like it's shown here in this image. You see the ablation lesion here just in front of the ridge. And there is interesting research going on trying to figure out whether these metrics, these MR parameters, could be predictors of outcome after ablation. We've done so far a case series of around 30 patients. 15 of them were included in the visible AFL study. And for some of the patients, 15 of them, we had a 2-year follow-up, and the procedure success rate is 90%. All the procedures were made on an outpatient basis. We didn't deplore any complication, and there was no recurrence of flutter at 2 years. So in conclusions, the interventional CMR-guided flutter ablation is a safe, feasible, and accurate technique. It can be done under conscious sedation and in-room monitoring. It requires deep transformation of the CMR lab. The ICMR system closely mimics the conventional electroanatomic mapping systems. What is really interesting is there is no ionizing radiation. You can visualize all cardiac structures and surrounding anatomy and the complex anatomy of the isthmus. The interactive catheter tracking is mandatory if you want to do this technique in safe conditions and convenient conditions. And interesting to notice that you can visualize the ablation lesions, and that can be really interesting for the prediction of outcome. Thank you very much for your attention.
Congratulations for the excellent talk, Jerome. We enjoyed so much. My question is, until now, until recently, when you use the hemodynamic lab, how do you perform the ablation? Blindly, without knowing the area? Just pressing the catheter and find the area? How do you do?
In the catheter, in the cath lab?
Yes.
Yes, they do it really, it's really fast. I agree, it's faster and it's more convenient.
But it's blindly you push the catheter, or you have some image. It's only use the catheter image.
Yes, they have a catheter image with the X-ray, so they have the projection of the catheter image, and then they do it just blindly with the catheter, with the projection on the scopy, and then drag a line between the tricuspid to the inferior vena cava.
With CMR, we have the choice to check and choose a specific point to perform the ablation, which is also very important.
Yeah.
How did you decide about right atrium?
Sorry, Sophie, I did not hear you.
You decided to perform the ablation in right atrium. Maybe you perform it in any other place. How did you decide to perform it in right atrium?
Just for, we only did patients with typical counterclockwise flutter. So we know in those cases that you have to ablate just the CTI line between the tricuspid valve to the inferior vena cava. Only very typical counterclockwise flutter. We didn't ablate so far complex flutters.
Oh yeah, okay. Congratulations, great work, and I'm happy because we have the opportunity to introduce ICMR in our 10th anniversary of Athens CMR course. So thanks a lot.
That's my pleasure, Sofia.
May I have another question, if I may?
Yeah, sure.
Great. So if I have it so well, although I had some technical problems at the beginning that I did not enjoy all of your talk, you have enriched your lab beyond the traditional devices and traditional X-ray with a CMR system. Is this correct?
No, that's not correct. Actually, the two labs are not at the same place. They are on different stairs in the hospital. We have a regular catheter lab and a regular MR lab that is not at the same place. So just the MR lab needs to be transformed with the EP configuration, but it's not an hybrid room.
Okay, great. Theoretically, if there is enough space, could be also this one or not?
Yeah, that could be done. Yes, for sure.
Yeah.
In some places they have hybrid rooms. It's you need some place. It's complicated, but yeah, it does exist. It definitely exists. Yeah.
Okay, great. However, it is something very innovative and something which needs to be considered in the first priorities from the CEOs of the hospitals and also by the physicians, CPs. Yeah. Which country you are practicing? Sorry, which country you are practicing? Garot?
The country is France.
It's France. Okay.
France. Yeah. And, Paris area. Yeah.
And in Paris area. Okay. Great. Thanks very much. May we have to proceed to the next presentation or not, Sophia?
Yes, please proceed.
Okay, great. So, thank you very much. Thank you very much. So, it's my great pleasure to introduce Professor Sviter, who is going to present an overview of a large case series. So, Professor Sviter.
Maybe he has a problem with the phone, something. The microphone. Otherwise, we can move to the next speaker if it's not possible for him to present right now.
Okay. To